Welcome to Functional Roots, where whole body wellness begins in the mouth. I'm Amanda.
And I'm Heather, and we're hygienists with a passion for all things holistic, functional, and naturopathic.
This isn't your average dental podcast. Around here, we dig deep, past the plaque, and into the powerful connections between oral health, the body, and the way we live.
So whether you're a fellow dental professional, a wellness enthusiast, or just someone curious about taking a more natural approach to your health, you are in the right place.
So grab your favorite herbal tea, settle in, and let's get to the root of it all.
Awesome. And today we are welcoming my friend, Claudia Porta, and she's an MD out of Florida that I work very closely with oral microbiome testing and consulting with her on the oral microbiome.
All right.
Very nice meeting everyone.
Thank you so much for being here. And this is a whole lot of things. So you are board certified American Board of Preventative Medicine and Public Health diplomat of the American Board of Obesity Medicine, board certified American Board of Anti-Aging and Regenerative Medicine. Dr. Claudia Porta received her MD degree from the University of El Salvador School of Medicine in Buenos Aires, Argentina in 1997. In 2002, she completed her international medicine residency program at the University of Buenos Aires School of Medicine and her requirement, not retirement, for the degree as a specialist in internal medicine. Dr. Porta continued her medical training at Jackson Memorial Hospital, University of Miami School of Medicine, completing a fellowship in special immunology and her internship in general surgery. She completed her second residency at the Palm Beach County Preventative Medicine Public Health Residency Program and also her master's in public health at Nova Southeastern University in 2009. Currently, Dr. Porta has hospital affiliations with Wellington Regional Medical Center and Jupiter Medical Center. Dr. Porrata founded Lifestyle Medicine Specialist in 2012, where she continues to dedicate her medical career to the area of preventative and lifestyle medicine. Fluent in English and Spanish, her main goal is to make an impact in patients' disease, prevention, and health optimization.
Yeah.
That's a lot. That's a mouthful.
Yeah, she's got a wonderful background on so many cool things.
I've had a long time to
Yeah. So happy to have you here. And I love being able to tie the oral systemic connection. I'm speaking tonight for Bristol, tying the oral gut access together on that. So we get to do that on a weekly basis together on reading salivary diagnostic tests and working together on the health of your patients through that. But you have one of the most diverse and comprehensive medical backgrounds. It's super exciting to have you here. So what initially sparked your interest in lifestyle medicine, and how did that foundation shape your way to practice today?
When I came to the US after being an internist in Argentina, which is my country of origin, you have to go through all of the certification pathway again, etc., doing the residency program again. And going back to internal medicine was a little challenging at the time. And through different avenues in life, I found the different option, which was preventive medicine and public health, that opened up different doors, and especially a door into lifestyle medicine, which would encompass not only chronic disease, which is what you do mostly in internal medicine, but a door into just improving people's lives, looking at environmental factors, lifestyle factors, food, nutrition, etc. And that applied more to what I wanted to do than hospital acute or chronic disease care. Once you open the door of lifestyle medicine, then you start seeing other problems in a different way. You start looking at chronic disease in a different way, especially obesity, which was my interest initially. And back then, believe it or not, obesity treatment was not what it is today. We did not have the medications available that we have today. We didn't have the tools that we have today. We had a completely different outlook on the problem. It took a while for obesity to be taken from just a simple calories in, calories out, eat less and exercise more approach to let's try to figure out why this person has this expression of disease in their excessive weight and what else is wrong. At the same time, I was approached by the functional medicine community that was also like getting started and getting to be more mainstream and having more access to education, proper education that you could actually implement. And once I started looking at the two of them, they had a lot in common. And what they had in common is they stopped looking. I realized that they were not looking so much at the symptom, but what was the process of getting there. And looking at things a little different than what we look at in internal medicine, which is the outcome. This is how the patient is presenting. What are we going to use to just stop it or making it look better? This is looking actually at the process of it. If you start looking at how the pathology starts developing, then you open a different box. And I don't know, 15 years later or something like that, which is today, my way of looking at patients is more functional than not. And if you're going to dive into the function and how things develop, you're going to end up looking at microbiome. And unfortunately, after doing a little bit of research, I was able to find results and start working with Heather, which is educating me in dentistry first. And then what is it that we're finding and how we can apply it to our patients. Patients are quite sick and they might not be as sick if you don't dive into some tests, laboratories, microbiome testing, either oral or gut functional testing, etc. If you just look at the patient and you do the basics in internal medicine, which is some basic blood work and their weight and even their BMI that we're trying to get out of, like what that weight means to how tall they are. We're getting away from that because it doesn't really reflect the extent of the problem or the disease. If you just look at that and you just have a person that is large or is larger than what it should be, and maybe you will find nothing in their blood work and still that person is incredibly sick. And the potential that it has to develop disease is incredible. Fast forward, okay, we have a population that is very heavy in the US, and then we have a lot of cardiovascular disease, we have a lot of cancer, we have a lot of this, a lot of that. They don't fit together, actually. It's the same patients. It depends on how far you let them get sick. And if you don't really dive into what's the background of these problems, if you just take the face value of just their weight and their BMI and the regular things that we normally test, you might not find a thing. And that person is going to walk out of your office feeling still very sick, not comfortable, having sleep problems, inflammatory problems, and none of them are being connected. So it's like summarizing, that's how I ended up. You start peeling and finding out how things develop, and you start getting a little deeper into, okay, what is the cause of this? And something that I've been trying to see, it's because we've been doing gut microbiome testing for a long time. At some point, I started seeing that most of my patients were coming with something else, either in their mouth or whichever, but medicine, internal medicine or preventive medicine, whichever. You don't really dive into that. But I started seeing that the patients had way too many problems in their mouth and it's the complete disconnection, and they're on their own. So at some point, I just figured that it has to be something for the mouth similar to what I'm doing with the gut. Let me go and find out. And now that we open this new box, now we have to learn a lot. Me, at least, because I don't know. And that's why Heather needs to meet with me every week.
It's been super fun for me because I get to learn a lot of the medical side of things and some of the things that like you're teaching me on certain pathways. And then I get to talk about amalgams and fluoride and how that is problematic for thyroid health and Hashimoto's and tie that in, and then obviously the oral microbiome. We've found some.
And I think our relationship reflects what's going on nowadays, which is oh my God, you do what? Complete disconnect from your side to our side and our side to your side.
Yeah.
The dental history is not part of it's not part of the regular clinical history. You go through review of systems and this head, ears, nose, and throat, and nose and throat. It's in the back. And there's nothing here. And unless the patient will tell you I can't speak because I have ulcers in my mouth, the rest of the documentation gets lost, and we really forget to ask. And because the patient's going to the dentist.
Yeah.
Best case scenarios you have in dental clinics, or if there is, for example, a need for antibiotic prevention in certain patients with either valvular problems or hardware in their body, we're just not aware of anything else. The dentist is taking care of that. And I don't really know what you guys do, and you guys don't really know what we do. And that has to be modified. We have to start collaborating a lot more.
I have never honestly thought about the fact, in dentistry, we ask for a medical history form. But you guys, yeah, it's not even asked. I have never even thought about the fact that there's no question a doctor would never ask about the mouth, like you're saying, unless they're coming in with sores, or maybe they're there for an emergency toothache, an acute infection, something like that.
Patients
it's
don't
interesting
complain about that to us either. The patient will call the dentist. They will not complain to us. So it's just, I don't know, it's been like that forever. And maybe now that there's a little bit more awareness that there might be some bacteria in your mouth, there might be something going on over there that might be related to Alzheimer's disease or any cognitive problems and heart disease and immunologic problems, autoimmune disorders. And tell the truth, patients find out before us, and they come with that question. And when they come with that question, what are we going to say?
And I have to
go to your dentist.
Yeah.
I have to say kudos to you for diving in, because there isn't a lot of open-mindedness. I just had a conversation with my grandma. She's got no ability to reduce dietary nitrate into nitric oxide. She's got blood pressure issues. She's got all these health issues. I implemented a whole healthcare. Her primary care physician in Florida basically said, if you have oral issues, you should be seeing your dentist. And I don't want you doing any of the oral care that your granddaughter has given you, because there's no science behind what she's telling you. And I was like,
for those of you not watching, Heather just flipped them off.
Because there is so much science, Claudia, and
the science is going to become more overwhelming, and we're going to have to figure out what to do. When a few years ago, when finally the Medical Association decided to call obesity a chronic disease, it was revolutionary. It was a huge fight in the medical community, and for many different reasons. We still wanted to keep the blame on the patient. So changing things in medicine is very complicated.
Yeah.
And changing view from the physicians of something that we have been doing for such a long time is very complicated. There are things to this day. We're looking at patients, we're looking at evidence, etc. And you wonder, how come I never saw this in medical school? How come I don't have an education on it? How come I didn't know? And it's just hard. We are hammered with certain information to be safe and in part to protect the patient and to work within what. But then we have to evolve and continue our medical education, etc., and see what's out there that might help our patients. There's more and more information on the oral microbiome and the gut microbiome too, and what that is, and how is that impacting your patient. And even if this is not our area, at least we cannot ignore it.
Right. Mm-hmm. Yeah. And I mean, you mentioned sleep and breathing. Hey friends, Heather here with Functional Roots Podcast, and I'm incredibly excited to share some really cool news. For the past few years with working with Bristle, I've had so many practices, dentists, hygienists who are asking this question: where do I get trained? like you on the oral microbiome. And I'm super thrilled to announce that I have been taking the leap into creating a new space. So my website, heatherkenneyrdh.com, is now live. And I'm gratefully collaborating with Janice through Den Credits to bring you PACE certified CE through courses that are available now on my website. This platform is designed not only to educate, but also be a community, a place where we can support each other through CE courses, webinars, and eventually I'm hoping to have a membership hub. My vision is to create an ongoing community where we can gather for open microbe nights, where we can share discoveries, discuss clinical cases, and keep an advanced conversation on the oral microbiome and oral systemic health. So I'd love to have you check out and join in and be a part of the next step of expanding biologic dentistry education. So please visit heatherkenneyrdh.com. It's now live and ready to educate and share.
There's more and more information on the oral microbiome
There's
and the gut
there's
microbiome
over-
too, and what that is and how is that impacting your patient. And even if this is not our area, at least we cannot ignore it.
Right. Yeah. And you mentioned sleep and breathing and obesity and cardiovascular disease. Like we've talked about this, where looking at sleep apnea and how that plays a role in inflammation. And I talk about that all the time in dentistry, that we have to look at how people are breathing and how we have sleep apnea issues and that cascade of inflammation, but that plays a role in obesity and how people, their cytokines, their interleukins, and that sort of thing. So, and it influences the oral microbiome profoundly by reducing those nitrate reducers, and then that has a cascade on the blood pressure issue, which if we're stopping breathing at night, that's gonna also cause some cardiovascular risk factors. So we can't ignore the mouth anymore in medical.
And it's
We're learning the same thing in dentistry. You're driven this education here, and we're not supposed to look outside of this box, but there are some of us that are starting to look outside at this box and what else is impacting health, both orally and systemically, from the mouth, and how do we make changes there? So I love that you are so open-minded. And
yes, when I started the functional medicine program, American Academy of Anti-Aging Medicine, they have been around for a long time. They're probably one of the leading organizations in functional medicine and metabolic health. They were looked as outcasts, and or maybe that they just had a purely an economic interest in medicine, pushing supplements or pushing hormones or pushing whatever. And the truth is, people are understanding that we have to dive a little bit more into the physiopathology of the problem. Like, how did the problem develop? How did it get wrong? Why don't we treat that? The approach normally for a lot of things is just the end result. Like, how do we, okay, if it's high, how do we lower? If it's low, how do we heighten it? If you're too large, how do we shrink you? If you're too small, how do we enlarge you? And not the why. How did I get there? And I guess there is a functional part in dentistry. The way that you're describing the pathology with the oral microbiome is purely functional. Okay, you have this bacteria. It will either react with this, or it will not be recognized, or will overgrow, or it will cause these inflammatory factors. It goes from here to here. It's purely functional. That is the physiopathology of the problem. Okay, this is going to produce, this is going to affect this. How do we change that instead of, okay, we have this here, how do we lower it? So it is a purely functional approach, and I'm not sure how dentistry is adopting oral microbiome, because really I don't have a lot of connections in that area. But dentistry seems to be very much oriented to procedures. And being an interventional specialty in medicine, we have surgery, interventional disciplines, and we have purely clinical disciplines. And patients flow from one to the other normally, but in dentistry, you don't have a clinical dentist and a procedure dentist. Dentistry is procedural. And then there's you guys in the middle that probably do most of the education with the patients. I don't know how dentistry is adopting. Okay, let's try. Okay, this patient is coming with all sorts of ulcers or periodontitis or gum recession. Besides doing the procedure, how do we prove that? What happened? What is the patient eating? What are the systemic problems they having? Are those systemic problems contributing to this? That's clinical. You need to sit with a person, probably not in a chair. So how do you go into that? How do you change that? But little by little, functional medicine was nothing and outcast. Bariatric medicine was nothing and totally outcast 15 years ago. And now it's very much mainstream. So this is probably just evolving. It's quite new.
Yeah, I think one of the few advantages that a clinical hygienist has is that we are one of the only providers that has 1 hour with a patient. And that gives us clinical time and it gives us chairside, just education time with the patient. And every practice is going to be different. I work in accelerated column, so I do double hygiene, but my time with my patient is clinical. And you're going to master it, right? Like when that patient can't talk, you're talking, you're doing the talking. So we are so uniquely set up in dental hygiene to be so much more valuable than what the box that we're put into can provide. And again, we can always get political on this one really fast with dental hygiene. If we had autonomy to be able to bill out more services, to be individual providers, man, that clinical functional side of things, because imagine being able to talk about salivary testing, mineral tests, doing more gut, tiny health diagnostics. It's all one tube, like it's all connected. So why can we not have that collaboration with functional providers in our communities to be able to really reach, okay, why is this patient getting the ulcers? Why is this patient having that uncontrolled periodontal disease? I actually just saw a patient yesterday. I knew it was going to be a bloody scaling and root planing. Like I was prepared for it. It was the last patient of the day. The bib was just blood when we were done. And she has like the classic, she has a lot of stress. She works the night shift. She just lost her mom. Like just name it and she has it. Just high blood pressure. She's just like a depressed person. Just so many things. And I'm talking to her about, I can do my best job here getting rid of this calculus under your gums, but this isn't going to fix the inflammation. You have so much systemic inflammation happening. I would love to test it, but I know you've got so much systemic going on that trying to just reassure her, this isn't you.
There.
Yes, absolutely. Tying it all together for her. So I love that there's providers out there like you that get this and are starting to connect. Hey, maybe we should be talking about a dental intake form at your medical provider's office.
That since I've been talking to Heather and getting more educated, I know a little better what to ask. But it's instant; it just clicks. And even though we don't examine the oral cavity the way that you guys do, we do the nose and throat inspection, and you can see the Malampati score, and you can see the turbinates are inflamed, and you can see the just the face and the neck. And you can tell whether there's any air going through or not. So, and even without going into counting teeth and things like that you guys do, we can get a lot of information there. And once Heather opened my mind to a little bit what's going on there, and that was like it clicks.
Yeah,
it
and
makes
even
sense.
that close, you can smell, right?
Yeah.
You can smell.
Well, and
Yes.
we talked about, okay, so in your area, who's treating Airway and where should we start thinking about myofunctional therapy when you're starting to see all of those other things? So it's beyond just oral microbiome that I get to teach with her. It's like the foundation. It's so fun to learn what she's learning through the salivary testing and the progression of people getting better and reducing CRP and interleukins that she's seeing through shifting the oral microbiome, but then also educating, okay, we know this person has sleep apnea. How can we support them even beyond just using a CPAP machine? Are you looking at the Malampati score? Have you considered collaborating with an airway specialist in your area? In dentistry, where we could do myofunctional therapy and have a better approach for the sleep apnea if we can. So it's been a fun.
And even in the patients that I haven't done result tests, I'm just looking at them differently now. Because I know there's going to be problems there. With the products are regular dental products that people are probably not looking at. I am asking what is it that they're using now just to know. And of course, everybody will give me the supermarket list of products. And having this other approach, of course, we have been treating sleep apnea in medicine forever. But now if I understand that sleep apnea is causing my patient's inflammation, even if I don't do the test because the patient might not want to pay for it or whichever is the case, or they're not interested or something like that, I can ask them, so what are you using? What are you brushing with? I know that they will have dry mouth. I know that they will have this or that or whichever. And even with things that are no treatment but are basic, I know they're better than what they were if I just change their products.
Yeah.
So it changes the approach to the pathology that they have so radically. It's mind blowing, and you see the results. If you just it's what Heather says. If you just put a CPAP mask on somebody, they don't improve. And how many patients are out there like putting on a CPAP? They might hang it next to the bed or something like that, and they don't. And then there's the medical part. Then so what medications are they on besides the mask? What are those medications doing? Maybe to the oral microbiome or to anything else, but everything starts clicking. And it's just a different understanding of the pathology. Also, how many sleep studies are we doing? I probably was doing too little. Because not everybody with obesity not every sleep apnea patient has obesity or a big neck, or not the extent of obesity that we might think. Because the neck is not everything. And how many more people need a sleep study than what a regular screening is telling us to do? And even if it's not sleep apnea, even if they're not stopping breathing, what about mouth breathing when they're sleeping? That might be changing my obese patient's pathology.
Or even mouth breathing during the day, not even just at nighttime, all day long.
Mm-hmm. Yep.
Yes.
Yep.
So it's
Claudia,
quite.
I have a question. So I don't know the answer to this one, but how did you start Bristol testing? Obviously, everybody's going to know we are connected through Bristol because you started training with me there, and now we do consulting together. But what made you start to think about salivary diagnostic testing?
It was a particular patient that I had got microbiome testing on with certain bacteria that I thought was causing inflammation, but then wasn't fixing the problem. And I'm like, I don't know what she has in her mouth.
Yeah.
I don't. So I immediately called, and I was thinking about it, and then I called the company, what's a renowned company that does the gut microbiome testing. We've been using them for a long time. They are a reference in the industry. Could you please do the same with the mouth? And we understand what you want, but we don't do it. Yeah. And I asked him, could you refer me to somebody else in the industry that might be doing? And they didn't know what to tell me. No, we don't, and we don't know anybody. So started looking and getting into the websites and looking at the test results. And what caught my attention from Bristol in particular is that the DNA testing of all the mapping is very similar to what they do in gut microbiome. Then how you present the results, which is, this group does that, etc. There's something similar in gut microbiome because they have to allow the practitioner to understand what you got. Because otherwise you just have a map of 130 different bugs in there and you don't know what they do. I thought that Bristol would be more help. And then fundamental to me is if they have an educator, because I'm going to do the test and what am I going to do with the results? The education part was like very much resembled to what we do in gut microbiome. But yes, it was that one particular patient. And after that patient, for some reason, I had 2 or 3 that had way too much dental pathology, and they are on their own.
Yeah.
Between them and the dentist. Chlorhexidine for everybody, peroxide for everybody, and I don't know what that's doing. It wasn't so much. I knew we have information on cardiovascular disease, Alzheimer's disease that everybody now is interested in, and bacteria in the mouth. But what pushed me finally was this one particular patient just couldn't figure it out, and I'm like, I'm sure I'm missing something. And ended up with bristle. What makes it also eligible is the price.
Yeah.
The price has to be reasonable.
Yeah.
In patients that we're doing a lot of medical care and things are covered by insurance. In functional medicine, a lot of things are not covered by insurance, and you have to be mindful of that. So the test was reasonable.
Yeah. 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 And you've had really interesting, a lot of your patients have had some of my favorite topic species where we're dealing with Citrobacter and Klebsiella and some of these species that overtake an entirety of the oral microbiome. And we're dealing with treatment of that and reducing and then rebalancing and resetting after. So it's been fun to see how, for me, like how those actually are presenting not just in the mouth, but how they're impacting systemic health in those inflammatory cytokines that then I become super passionate about talking about those pathogens because they're not the typical pathology that we talk about in dentistry, but it's been my passion now to have that conversation with everybody on what about these atypical pathogens that can take over an exuberant amount of space. And I have a lot of your patients who have had some of those, and it's environmental. We've established some of your patients are outside, they're construction workers, they're working in barns, so they're exposed to mold, and those Citrobacters are sometimes tied to that mold component and some of those factors where we're pulling them from the environment, and then they become extremely opportunistic in the oral environment, and then we swallow them, and it excites inflammation in the body.
To patients, patients understand exposure and outcome, and they don't put onto like the interface is the mucosa. And once you tell them the reason why we're testing this is because there are a lot of things that can come through skin or breathing, but then you have a huge amount of surface inside your gastrointestinal system. Is huge. Mm-hmm. And then they finally understand that the reason why I'm going there in the gut or in the mouth is because that is where it happens. And now we're understanding what we're doing.
Yeah.
The interface is there. How do you connect? Okay, sugar is not good for you. Okay, how do we connect it? With sugar is not good for you. Okay, because it comes here, it changes this, and now it makes sense. If you give the patients the power of understanding their pathology, they own it. Now they can rationalize it and make the changes. If you just tell me, take this, going nowhere.
Yeah.
Because why? It will last 1 week, and then there will be no compliance.
Yeah.
Here's that you're mentioning your grandmother and like she wasn't allowed to use the products that you suggested, etc. Since we started doing this, we started testing microbiome. And we're changing what the patients do. Of course, of the 15 instructions that I give the patients, I'm hoping for adoption of 3. That's what normally happens in medicine. You tell people to do 15 things, you'll get 3. So focus on those 3. With those 3 things that the patient might be doing, they're 10 times better than what they were when I found them. And I know that I'm changing the course 3 degrees. And that ends up with a lot of gain at the end. And patients come back feeling better. So medicine is frustrating. You don't fix a lot of things. You just treat them. And when patients come back and they're like, I hate the toothpaste that you gave me, but oh my God, this doesn't burn anymore. My tongue is smaller. These are things that I have heard from my patients. Like my mouth feels completely different. I feel better. I don't have inflammation. They do change. And I know that they're not doing half the things that I told them. But little by little, I know that they are better than what they were with what they were using. That was doing nothing or maybe harming them.
Yep. How cool is that?
Quite interesting.
And we treat the oral microbiome, and the patient comes back and says, my tongue isn't as swollen.
Not just oh, it's just a condition you have. Like I
Right.
remember tongue scalloping, you learn your landmarks in dental hygiene school, and I just so distinctly remember learning scalloped on the tongue. And it's just a landmark that you look for. And then it became, oh, the tongue is just too large for the mouth. And then it's an airway issue. I've been a hygienist 18 years, and Heather and I have been practicing about the same time. It's just so interesting, the things that we learned in school, landmarks. And tori is the same thing, right? We know that's associated with airway issues. And it's not just, oh, patient has too much bone, their osteoclasts are too stimulated. It's, no, they probably got an airway issue. They're doing some serious clenching and grinding.
Yeah.
And it's more than just, hey, let's give them a plastic night guard to protect their teeth. It's, hey, what if we actually care about their airway? That's a thought. I don't
Yeah.
know.
This kind of like the source of the problem. They
Exactly.
go to the source and try to fix it. And it's not that much more work. But what I see with you guys in medicine, we have different levels of practitioners. You have the physician, and then but then we have a PA, and we have a nurse practitioner, and we have a nurse. And seems that is missing in dentistry. You have the dentist and you guys, and there's no different level for you, nor for you. For example, if you have 1 hour with a patient, why couldn't you order the CRP and the set rate and the interleukins, etc., so you can see whether the impact of that or whatever applies to that particular case, and you could probably complete a little bit more of the circle. So I guess it depends very much in dentistry, the setting of the practice and what the practice specializes in, etc., to see how much you can do with the patient.
Yeah.
Now, patients are open to it.
You're absolutely right. I think there's certain states where hygienists are allowed to practice independently, or they have an advanced practitioner status. And one of my cohorts, I know she orders mineral testing for her patients in her practice as well. And she really goes down the nutritional side of things. But they do salivary diagnostics as well, which is a really powerful tool. But let's just be real. The majority of dentists aren't looking at that, especially outside of the biological space. Dentists aren't looking at that because I'm not going to say because, that's just not what they're trained to think. That's not their line of thinking. So I love where you're going with this, Claudia. Yes, there should be like a hygiene practitioner where we can order labs, where we're looking at the systemic aspect of things, because there's so much with dentistry where you're saying there's a clinical dentist that's doing surgical things. Hygienists don't want to do surgical things. Most of us don't. We love a good blood situation. We love treating perio, but we don't want to fix teeth. We really want to look at that oral microbiome. We want to manage periodontal disease. We want to prevent these diseases from progressing, not just dentally, systemically. And I think you're right. There's patients that want that. That demand is starting to come.
And I feel like that's what I like to do. And that's what I'm enjoying with my relationship with you, Claudia, and even my bridging the collaborative conversation. I just had a periodontist yesterday that I did a bristle consult with. And then we talked about, okay, maybe you should connect with the Atlanta functional medicine practice, because you're doing X, Y, and Z, and you're starting to salivary diagnostic tests, but we also have to look at the complete picture. I teach the triangle, like the airway, the gut, and the mouth. And we can't treat the mouth without looking at the triangle elsewhere. So we have to pull out some people in left field to start working collaboratively, because it's not always about the bacteria either. And we have to start looking at this inflammatory cascade. Yeah. What's happening systemically that's feeding disease? What's happening on a mineral component? And I have that conversation with dentists all the time. Like, it's not just the bacteria that causes decay issues. It's saliva flow, it's pH, it's frequency of eating, it's malnutrition. It's inflammation leading to gut dysbiosis issues where we can't take up our minerals to start. So we're not going to fix the decay issue with fluoride if we don't have the minerals like calcium transported properly.
I
And then
think it makes me,
phosphorus.
I am the reason why I'm reviewing all the tests with Heather is because I we can only go so far with what we do. And what we try to achieve in either internal medicine or what I do is you just have to have enough education to know what your patient needs and then refer them to the appropriate specialist. We do that with all of our own specialties. I go only so far with pulmonology or neurology or cardiology. Then from then on, my patient needs to be in the care of a specialist. So probably, and with all of the advances in research in the relations with oral microbiome and everything else and systemic disease, all of that medicine needs to know is, okay, what are the testing available? How do we do that? And once that test comes back, which is the just initial part of the care and diagnosis, once you have that, if it's not good, you should have a place to send your patient to somebody that really knows about this. But it would be something that is not ignored anymore. In the meantime, it's just lost in translation.
Yep. Yeah. Yep. And my mission, and I think Amanda's mission, why we're doing this is to spread the word. And then I have a website where I'm educating, and I'm hoping to excite some of these hygienists to start really becoming oral microbiome detectives and practitioners so that we can be more collaborative with doctors like yourself and give you more tools for referral purposes so that we can maybe bridge that gap a little bit more.
And besides what we try to do with her, with my patients of the initial approach, etc., the patients have access to the records and I ask them to take them to the dentist. Whether the dentist is interested or not, then it's beyond me. But at least I try. And tell the truth, even if I'm not doing as much as you guys would do, and I'm just following directions and trying to understand, with the few things, like I said before, with the few things that I tell them, it's amazing the results. How you finally break through things. They do get better. Their labs improve, their conditions improve, and that is not even doing it at 100%.
And that it's super cool, Amanda. Last week, I think Claudia mentioned she had one of her patients go to the dentist and they actually commented like how much improvement they had seen in the oral environment just with the few changes that her home care recommendations made based on the bristle test.
That, I'll be honest, that's like amazing that they're, I don't say humble enough, but like open-minded enough not to get offended and say, don't ever do that. We're the professionals.
Yeah.
To listen to you. So, do you have a case study you would love to share with us? Maybe one, I would love to hear one around like insulin resistance, if you happen to have a case study about insulin resistance and microbiome testing.
Yeah, more than a few. And we have one before we go to that.
Yeah.
A patient that we will be probably working with, but it's a patient that I only treat for obesity. She's not a primary care patient with me. But in any case, strong history of Alzheimer's disease. Mother and all the females in the family, all of them. And with their early deaths. And of course, she's early 50s and worried about symptoms, part of a particular study. And I have mentioned her, I'm fixing everything else that I can fix. And I mentioned the last time, I want you to look at this online, see what you think, get the test done. If you end up having the test done, I will send you in the right direction. We'll find you somebody to see you for that. And okay, went by. Today, that was asked from the patient. That was asked. She asked me, actually. The test that you mentioned before, I went and did a little bit more research, and I did some research in the family history. All of them had periodontal disease. All of them. A severe periodontal disease. And she told me, and I have gum recession, and I'm scared. And it's like what I've been reading, etc. This is quite striking. And of course, she has the genetic mutant, the ApoE4s, etc., that are associated with Alzheimer's disease. But then when she went and found out in each one of the family members if they had or not periodontal, they all had periodontal disease. And so that to me was quite something to hear. What I told her is, with all the lifestyle changes that she had made, among them alcohol, stopping drinking alcohol, etc. I told her, probably you're a lot better now than what you were before, because everything that you did would probably impact your oral microbiome. But in any case, if you still have some gum recession, for which she's being told nothing about, she's just going every 6 months and nothing. She's definitely going to go for a test. That is one. Then there's another one that we did a test 3 months ago. So I decided not to treat her based on that test. This is somebody that is not very compliant. It's a young girl. With, and this is the only patient that I have like that, an elevated white count. So you have elevated CRPs, elevated cell rates, elevated ferritin, elevated fibrinogen, elevated inflammatory interleukins, etc. But elevated white count, high white count, 11,000, 12,000, 14,000, for which I have studied her. I've sent her to the hematologist. I just need to know that there's no myeloproliferative disorders here, or where is this coming from? Because white blood cells are not an acute phase reactant, except for platelets. And this has been like that for a long time. So for sure, big neck, malapathy, etc., the whole package. And finally, she did an oral microbiome test 3 months ago, and it came back horrible. Lost to follow-up, etc. I finally sat down with her and mom and told her, that white blood cell count that we don't know where it's coming from. I understand the inflammatory factors, but I don't understand where this is coming from. It might just be this. I have not had her do a gut microbiome test yet because of the same situation. She doesn't do it, sit in the kitchen counter. And she finally understood. And she was always like, I don't have any problems with my mouth. I go to the dentist every 6 months. Yeah, I'm not so sure. And that the sleep studies has not been completed, etc. But this is a patient with a lot of oral dysbacteriosis and an elevated white count, besides everything else that is wrong. So those two are quite intriguing. In terms of insulin resistance, yes, I have patients that, since I'm dealing with the rest of the body, I can see the insulins coming down and the adiponectins going up and the CRPs coming down, and even interleukin-6 that I do anyway. You can see all of them improve, and you can see how their mouth starts changing into something completely different. So these patients they're very dear to me, and they're very compliant with what I ask them to do. If I ask them, go see your dental hygienist because I need an evaluation, they will go. And it's quite striking. And these are not 80-year-old patients. These are 50 and 40-something-year-olds that had a lot of pathology. And you wonder, okay, so what's this, the chicken or the egg? And it doesn't matter. You need to treat the whole thing. There's oral pathology that ended up in obesity. It happens at the same time. But then, like I tell them, because patients fight you on the sleep study, they don't want to get it done. I'll lose the weight and I won't have it anymore. Yeah, but if you have it and I'm not treating it, it makes it so much harder to improve. I think with the oral microbiome, it's the same thing. If it will improve with diet. But if you have it and we don't treat it, it's so much harder for inflammatory factors to come down.
Yeah.
And it's a lot of intervention and many different levels. I try not to drive them nuts. I know that once they leave the office, half the staff is left inside, but we work with them.
Yeah.
Come back, and little by little it moves.
And some of the strategies, like you said, just like taking them off Listerine or some of the chlorhexidine, which some dentists are still giving, but we're finding that just using biocidin and ozone seems to be a huge shifter for people on the biome. That's hard to get started, is utilizing just a few of those products and just getting them on a regular routine. And it makes it a profound difference on what's there.
Very much. They're a little different. And maybe they listened and they decided to put a little bit more olive oil or avocados or being a little bit more conscious about sprinkling some seafood into their week. Little things. Nothing needs to be drastic, but little things. It's amazing what you find. Another patient that I saw this morning, and this is opening my eyes. I need to do something different. This is somebody that is incredibly sensitive to carbohydrate. Sensitive. The minute she doesn't really watch what she eats, her triglycerides go through the roof, about 300, 400. I have seen 500 in her. Once they hit that mark, liver has a lot of inflammation. You get even pancreatitis. If you measure interleukin-6 and CRP, 10, interleukin-6 above 6, and that liver enzymes through the roof. And the patient that comes over like this, that can't move, everything hurts, falling asleep. So the minute the patient falls asleep during the day, narcolepsy drugs. There's older generation, newer generations, all of them perpetuate insulin resistance. They are taking those drugs during the day because they really can't wake up. And curiously, these patients will have an airway problem too. But maybe they don't stop breathing enough that the sleep study will be bad enough to justify the mask. So you have to start. If it's abnormal, I don't care if it hits the mark or it doesn't, but then fight with insurance, go back and forth, see what else you can find for them to get their mask, etc. In this particular patient, finally getting her mask, using Xlear, using a little bit more xylitol, keeping their mouth more moist, using the mouth tape, removing the medications that are being used during the day to wake them up, and addressing, in that particular case, it was thyroid. When the liver doesn't work, there's no T4 to T3 conversion, and these patients are, their metabolism, it's nothing they really they can't move, they don't have energy for anything. Replacing that, not because there's a thyroid problem, but there's a peripheral conversion problem, and liquid diet. Let's just stop the food. Night and day, different person. And now we can make progress with what's going on here. And mouth changed completely. So it's quite striking. You can untangle those patients just with a GLP-1, which is what we're doing. Here's your GLP-1, whichever brand you decide, and go home. Doesn't work.
Yeah. It's interesting because Karen has a very similar patient that had major issues, and they finally actually did palatal expansion and some airway stuff on more functional. So not just getting the CPAP going, but actually doing palatal expansion and dealing with the tongue posture and myofunctional therapy. And he's
They
so
breathe
much
again.
healthier. It's amazing what happens when we can breathe.
Yes.
And upper airway resistance, where you don't have all of those stops, but we still aren't breathing properly, has a profound impact on your health. There's sleep apnea where we're actually stopping breathing, and they categorize you in the severity depending on how many times you actually stop breathing. And I think you got to stop breathing like over 20 times before they think it's severe enough to put you on a CPAP machine, which, I mean,
For 80, you don't qualify.
yeah, which is insane. And that's where I think having tools where we have the right referrals. Okay, if we don't qualify for a CPAP machine, can we get you to an airway dentist who can at least get a mandibular advancement device and maybe a myofunctional therapy, and we can deal with some of the structural components of that airway resistance factor and try to get you breathing a little bit better if we can't get you qualified for a CPAP machine.
I just am stepping away from this conversation with the fact that now all doctors should be doing a medical or dental questionnaire.
Yeah.
Have you been diagnosed with periodontal disease? Do you have sleep airway issues? Has a dental hygienist ever told you your gums bleed easy?
Amanda, I just started asking, do you know this?
There you go. One of our easy ones is, when was the last time you saw your provider?
Yeah, most people do. I was like, how often do you go? And then I can tell whether they just go for the cleanings or they go for an annual visit or they don't go at all. And then, of course, I have the ones that are coming with the temporaries or Invisalign or anything else that they're doing. And it's amazing how the patient is not coming to tell me that unless I ask for it, because they don't think I have any interest in it. Some patients are patients that I have had for quite some time. So the obvious ones are the smokers. I do lifestyle medicine, so I cannot allow a patient to smoke under my watch. And we insist and we insist, and there's a mention of this, and there's a purpose to stop this. I will not leave them alone. But I was not considering the oral damage of smoking. I was just considering the cardiovascular damage of smoking, the neurologic damage of smoking, the cancer concerns, the pulmonary concerns. I was not thinking about how that was impacting their mouth, because that's territory of the dentist. And now that I do, I'm finding a world of information on, and I can tell the patient that I can tell them, this is what you're damaging. That is beyond your heart and your lungs and the vascular system and whichever. And they listen. And if they stop, it's incredible how much better things get and how much the inflammation comes down. And now they can put together, or I can convey the information that, okay, this will damage all the structures in your mouth and start causing autoimmune disorders and systemic inflammation. It is just a small step from there to cancer. And that is how it comes. Not only for like direct contact or the influence of the toxins in the smoking, you have one more avenue, but no one can explain it. And they can understand it a lot better. And finding out more. And sometimes it's just even asking them, okay, and what have you been treated for? And patients will tell you, I have conversation, no, I have 2 implants here and implant there, and what happened? And with that, you have quite some idea of where the patient is, some basic information.
So obviously you're, I don't want to say a unicorn, but you're definitely more on the forward thinking side, even in functional medicine, because you're integrating the dental and salivary testing. So for other physicians considering adding a salivary diagnostic or partnering more closely with dental professionals, what advice would you give them about where to start this conversation?
Yeah, medicine has just, no, I'm not talking about concierge medicine, which is what I practice. Just regular office visit, the time is very restricted. And the coverage for the patient is very restricted. And if the patient has a certain type of insurance or another, the doctor is very conscious of how much money it's spending on that patient. So it will all depend on that. But in general, let's say none of that is a problem, and the patient can come in and spend 20 minutes, and that's pure luxury with a practitioner, a nurse practitioner, PA, or physician. It should be like any other part of the body. We have to have an idea. We have to have a test that is affordable, if not covered by insurance, hopefully covered by insurance. But if not, it needs to be very affordable and get the return with good enough information so you can send the patient to have the appropriate care. Primary care will not have the time to deal with this. Like you sitting for an hour with a patient, you're the right person to deal with this. And I think primary care right now, and there will be more information coming out and more research and more robust research that telling us that we cannot ignore it, to the point that, okay, if you have a patient with advanced coronary artery disease, minimum cognitive impairment, or a history of Alzheimer's disease, Parkinson's, cognitive deficit of any kind, autoimmune disorders, you know what? That needs to be included in the workup. It needs to be quick enough and affordable in order to dedicate 2 minutes to it. That's what it's going to be reduced to. 2 minutes to the assessment. Here's the test. You see the patient back when the next appointment, maybe a month later or something like that, with their laboratory results for whatever it is that they need them, or whichever other diagnostic test, and here's your oral microbiome test. It's like, it's bad in this area, this area, this area. Here's the referral, go to the specialist and have that treated. If a patient comes to a primary care physician with obesity, with a BMI of above X, the patient needs to be referred. The patient will not be treated, even though it's like diet, a couple pills, maybe GLP-1. No, it needs to be referred to the specialist. So this should come to that same situation. There are very clear pathologies that are associated to oral microbiome things. Here's my 2 minutes for the assessment and the test. Patient should go to the specialist. So the specialist is taking care of that portion of your disease. You're gonna do the MRIs because of Alzheimer's disease, the MRIs and the specs and the labs, etc. And somebody is taking care of the oral microbiome, and the patient gets more rounded care. But I think it needs to come to that. So the patient can get to the appropriate hands, and this is not being ignored by everybody when the patient has acute coronary syndrome or Alzheimer's or rheumatoid arthritis or any other autoimmune disorder. That should be something in the list of laboratories and this pulmonary function, etc., the sleep study and all that stuff.
And you don't have to know
Um,
everything. The test kind of points you in the direction of, okay, we've got X, Y, and Z going on. These bacteria are tied to cognitive function issues, Alzheimer's disease, cardiovascular, diabetes complications. So many of the tests will indicate whether, and then it's just making sure they're getting to a dental provider who's going to
yeah.
assist
And
with
that.
that.
That can be on the primary care side, but then if the patient that has Alzheimer's disease gets to the neurologist and the neurologist is aware that it might be a connection with the oral microbiome, there should be the same way as with the primary care, a 2-minute assessment with an affordable test that can point you in the right direction to send the patient to get that taken care of. The rheumatologist, you're right to the rheumatologist, and you know what? Your rheumatoid factor is not positive, but you have all of the clinical picture. Crohn's disease, ulcerative colitis, we're not sure about ulcerative colitis, but Crohn's disease for sure, or IBS. Here's your 2-minute assessment for the gastroenterologist and affordable test. You need to go to a specialist, they will take care of that. And it would just complete what we're doing. If we're leaving that out, sometimes that might be why the patient is not making progress. And it can become like just a simple part of how we practice, just not ignoring it.
Yeah. And if they have cognitive function disorders, we have to look at whether there's amalgam mercury fillings in there. It's a neurotoxin. So when we have someone who's having neurodegenerative issues, MS, or any type of cognitive dysfunction, you should look in the mouth. If we have silver fillings there, we should probably consider having some of that taken care of, because that's also a profound impact on where dentistry can also impact systemic health.
Yes. And we're probably not looking at that.
No. Awesome. Where do you see the future of preventative medicine? Do you see like it being, could you imagine having one of me in your office?
Why not?
Right?
I'm not sure, because what you do is quite different and a different environment. But now if you need the chair for the physical part of it, then there's a different structure. You will not be able to support it in a regular medical office just because of the equipment that you need. But I do see the dentist office with something like a nurse practitioner in there that just does clinical care.
Yeah.
That can communicate, that can bridge with internal medicine or neurology or whichever it is in the referral process, in the back and forth.
I love
that should happen.
There's an office.
It's just an extra office in the dentist office with somebody doing just purely clinicals.
Yeah, there's a close office here, and they have a naturopath right in their office, which is awesome. And then I do have a practice that I'm working with through Bristol, and they actually have a nurse on staff, and she's reading all the salivary diagnostic tests and tying to it. So I've been training her, which is interesting. I don't know how she ended up from nursing into dentistry, but she has a nursing background and then can do some of this oral microbiome testing. And she has that biology degree to back that perspective up. But I really hope that we start seeing more collaborative care. I think our relationship has shown the importance.
Yeah, I think it's just a matter of the appropriate research studies, making a link that we cannot ignore anymore. So far as, okay, there's association. If there are more definite research showing a link that you're liable if you don't treat, then things are going to have to be, things will have to be a little bit more on top of it. But little by little, in many cases, patients push us in the right direction because patients are more in contact with things that might not be, or that are newer. That's in many cases how I end up doing research about certain things. Not in this one, I'm surprising them. But in a lot of cases, you end up doing research on things because patients come over with this that appeared in Instagram. They saw this is good for this or that. Can you tell me? And that's how you end up doing more research on things and then finding if there is some truth in it, what to do, how to approach it, how to incorporate it, etc. But a lot of functional medicine is not being ignored anymore. And probably in dentistry, the same thing. There are not so much from cardiovascular disease, but dementia, Alzheimer's disease, or non-Alzheimer's disease, patients are very concerned. So they will go the extra length on finding, okay, I don't care what my doctor says, let me find out. And taking matters into their own hands and making more progress. And then they push the medical community. Eventually, things just keep moving. Medicine's more and more and more, and we're starting to look at other things that impact us.
So on that note, what is something that you are reading and something that's one of your favorite podcasts to listen to just to grow your educational base?
Yeah, I tend to go back to the American Academy of Anti-Aging a lot, and for formal training.
Okay.
Because they have already screened everything that needs to be screened. So by the time they put a program together or a training workshop or whichever it is, you have certainty that the education that you're getting it's adequate. So I tend to go back to them. There are other organizations. I think Institute of Functional Medicine was a big one too. And all of them are composed of board certified physicians from very renowned universities that do cutting edge research on this. And then you end up getting the digested information from them. But it's not like you're sitting with somebody that had collected information from the internet and just put it together in a presentation and charge you money for it. And this is all of these trainings in any of these organizations come from very good sources. So I tend to go back to them.
Awesome.
I love it.
Super.
Claudia, thank you so much for spending time with us today and just sharing with our listeners just what is possible. I am a huge fan of concierge functional medicine, root cause, all of that. And I think that's something that resonates with all of our listeners. If they wanted to find you, reach out, become a patient, where is some way that they could get a hold of you if you're open to new patients?
Yes. Through I think our website has all of our information, lifestylemdspecialist.com. And we have a lot of patients from Florida, but we have a lot of patients that are not from Florida. They're here just for the season, but we take care of them year round, wherever it is that they are, within what we can do. So welcome to take new patients.
Awesome. Thank you.